So I'm going to talk a bit about DBS, what it is, what it can do to help, what can go wrong, and what the long-term outcomes are in patients that have DBS. I'd like up front to say that the company that makes the DBS device is Medtronic, and I've gotten money from them in the past for speaking, not today, but at other events, so I won't disclose that. And you're going to see some patients in the videos, in pictures and some videos I'm going to show. And we actually got permission from our patients to show them at events like this. I just don't want everyone to think if they come and see us, they're going to end up on YouTube someday. So, how many people in the audience have DBS? I know there are a couple. All right. How many have heard of DBS? How many have no idea what DBS is? Okay. All right. So you guys, we'll get you up to speed very quickly. So, DBS is short for deep brain stimulation, and it's essentially a pacemaker for your brain. It's a completely implanted device. There's a schematic of what it looks like. It's 1 or 2 electrodes that are implanted in a specific part of the brain that we know is involved in Parkinson's disease. And that wire is connected to a little battery pack, or what we call a pulse generator, that sits underneath the skin, usually right below the collarbone and the chest. And this battery sends little electrical signals to the electrode in the brain, and it can improve some of the symptoms of Parkinson's disease. These are a couple of skull x-rays of a patient with electrodes actually implanted. And in most patients, or a lot of patients, we put 2 electrodes in, 1 on each side of the brain. So you can see 1 on the right side, 1 on the left side. Some patients we only implant 1 side of the brain, and we'll talk a little bit more about that as we go. This is a close-up of what the electrode looks like, and this is the business end of the electrode, so this is what actually goes into the brain. It's small. It's about 1.2 millimeters in diameter. That's about the size of a number 2 pencil lead. And at the end of it, there are 4 little metal rings, and these are the rings, or we call them contacts, that we use to stimulate the brain. And if we pretend that this little orange blob is a particular part of the brain that we want to stimulate, and we put the electrode in here, we have a lot of flexibility. We can stimulate around one of these little electrodes, or we can stimulate around a different one, so we can change the location of stimulation within the target. We can have several of them on at once, so we can stimulate a larger area. We can also turn the stimulation up and down. So if we have the stimulation at a certain level, we're stimulating this much, but if we turn it up, we're stimulating more. And very attractively, if we get a side effect or we have an unwanted effect, if we turn the device off, it's like it's not even there. So this is a way of adjustably and reversibly altering brain function to try to improve symptoms of Parkinson's disease. Now, DBS is a surgical procedure. It involves an operation to get these electrodes into the brain and get the battery into the chest. And there are several ways of going about doing this. There's the traditional method, which is what we've been using for years now, and about 85,000 people worldwide have had DBS. About 1,200 of those have been here at UCSF. And the traditional method involves placing a frame on the patient's head, and the operation actually takes place with the patient sedated for part of the operation, but then awake for part of the operation. We get CAT scans and MRI scans of the patient before surgery with the frame on the head. That allows us to make basically a 3-coordinate map of the brain, if you will, and we can use these very fancy computer systems that we have now to pick a target in the brain and put an electrode there with usually a millimeter or less accuracy, so very accurately place these electrodes. Now, because we can't actually see into the brain during surgery in the regular operating room, we do this technique where we put a small little listening electrode into the brain first, and we listen to the brain activity in the area of these places where we stimulate, and that's how we make sure that we're in the right place. And in order to listen to the brain activity, we need to have the brain awake, and so that's why we have the patients awake. So we'll actually wake the patient up in the middle of surgery, do this mapping technique, make sure that we're really in the best possible place, and then resedate the patient, and then finally put them to sleep completely to put the battery in. And so that's sort of the traditional way, and there are many people in the room that I know have had it done that way. In 2004, we at UCSF started to develop an alternative technique where instead of doing the operation in the traditional operating room, we actually do the operation inside of an MRI scanner. And this is an MRI scanner on the 3rd floor of our hospital that is draped out in a sterile manner so we can actually do these operations with a patient asleep and get MRI images during the operation to guide the electrode placement. And so again, we can get multiple MRI images, and we can use the imaging instead of the brain activity to guide the electrode placement. And so in this technique, the patient doesn't have to be awake for their operation. Of course, the patient misses out on a lot of fun if they're not awake for their operation. So there are 2 different ways to go about having this done, and we do both of them at UCSF. So this is a typical patient with Parkinson's disease, and many of you will relate to this. Patient with very shuffling gait, very slow movements, very little arm swing, very stiff and rigid. This is my favorite video. It's hard to read, but his shirt, it says Parkinson sucks. You'll see when he turns around, he can't turn around like he used to. He has to take these multiple little hopping steps to turn around, otherwise he's going to fall over. And then again, very slow, shuffling gait. So this is very typical of a patient with Parkinson's disease. This is a gentleman that came to us from Idaho and saw us at the VA hospital. So this is him before his DBS operation. This is him now 6 months after DBS. And he's not perfect, but he's much better. He came to see us and follow up and rode his motorcycle down from Idaho, which gave our neurologist a little bit of chest pain. So that's in a nutshell what DBS is. So what I want to spend the rest of the time talking about is who's a good candidate for this, what can it do for you, what can't it do for you, and what can go wrong, what are the risks of having DBS. So let's talk about what DBS can do first. So there are sort of 4 or really 5 what we call cardinal symptoms of Parkinson's disease. And many of those can be helped with DBS. If you have dyskinesias, it's very, very good at suppressing dyskinesias. If you have tremor, it's very good for suppressing tremor. Tremor and dyskinesias are probably the 2 symptoms that respond most dramatically to DBS. If you have stiffness, that your doctor may call it rigidity, that improves with DBS. Slowness of movement, and this includes freezing episodes when your medications don't work well, that can get better with DBS. The shuffling gait, as we saw that gentleman doing in the video, that can get better. And finally, what DBS really does in a nutshell is it can take these on-off fluctuations. You're on, your medications are working well, and you're happy, but then very unpredictably often, your medications will stop working, and you're tremoring, or you're slow, or you're freezing. It will smooth out those fluctuations, and it will increase the amount of your day that you're in a good on state, and it will minimize the amount of time, the severity that you're in an off state. So that's really what DBS can do. But it can't fix everything. And there are many, many symptoms of Parkinson's that DBS doesn't help, and most of these we call sort of non-motor symptoms of Parkinson's disease. So things are things like swallowing difficulties or softness of your speech, which I have today. It can make those things better. Constipation. Some people have urinary difficulties. It won't make those things better. Drooling. It won't make that better. Memory difficulties memory problems are a very, very, I think, under-discussed problem, a symptom of Parkinson's just as much as tremor is, and it does not make that better. In fact, it can make it worse, so we're going to talk about that extensively in a minute. And so there are a lot of other things that it can't help, and so it's important to discuss those with your neurologist or with a surgeon if you get that far to really figure out, okay, what can I expect to get better? What isn't going to get better? Now, there are things that can go wrong, and so these are really the main complications of DBS. And the number one thing that patients worry about, that surgeons worry about, is causing bleeding in the brain. So we are penetrating the brain with electrodes, and there are big blood vessels in the brain, and there are also millions and millions of small ones. And the big ones actually aren't usually the problem. We can see those on the MRI scan, and we can avoid those. It's these sort of medium-sized or small vessels that we cannot see that we will bump into. And the vast majority of the time, nothing bad happens, but if you hit a vessel and tear it or injure it, bleeding can occur. Now, the overall risk of any amount of bleeding, whether it's a little eyedropper full of bleeding or a large amount of bleeding, is between 2 and 3%. And the good news is the majority of patients that have bleeding, it's a very small amount, and it doesn't actually cause symptoms, or if it does cause symptoms, they're transient, they don't last, they're not permanent. The risk of a permanent change in your functioning as a result of a hemorrhage is 0.6%, so it's about 1 in 200. So it's a small risk, but it's not zero. And people have been paralyzed, people have been put into a coma, and people have died having DBS. So the risk is small, but it's real, and it's something to think about. And we take extraordinary measures to minimize this particular risk of bleeding because it's really the worst thing that can happen. And we've gotten it much lower than it used to be, but it will probably never be zero. And it's just by virtue of the fact that we're penetrating the brain with an electrode. Now, infection is actually the second most talked about complication. It's actually a little more common than bleeding. The risk of infection is between 4 and 5%. And these numbers I'm quoting you, by the way, are our numbers from our program here at UCSF. But they really hold true pretty much across the country and around the world. Now, infection is not something that is life-threatening, but it can be a major inconvenience. If an infection is mild, if it's just on the surface of the skin, it can be treated with antibiotics and nothing more needs to be done. But infections that get deep, that are underneath the skin, that are in contact with the hardware, the wires or the battery, the only way to get rid of infection in that setting is to take whatever part of the system is infected out. Most infections happen where the battery sits in the chest, and that means going back in with another operation to take the battery out. We usually leave the brain wires in place, treat with antibiotics, get rid of the infection, and then at some point down the road, usually weeks or even a month or two down the road, go back and put the battery back in. So infections are not life-threatening, but they can mean additional surgery, and they can mean being without your stimulation for a period of time. And then finally, there's this sort of collection of other complications, electrodes not ending up right where we want them to be, symptoms not improving as much as we expect them to. And these can be caused by a variety of things. Sometimes we get the diagnosis incorrectly. We think you have Parkinson's and you have something else and you just don't get better. Or an electrode ends up not right where we want it to be. You know, I looked at through the literature a couple of months ago at what is really the rate of an electrode really not ending up in the right place. And the best number I could find was somewhere less than 2%. And that's about what we see here at UCSF. So it's actually quite rare with today's surgical techniques. The most important thing, though, about avoiding a bad outcome, the most important factor that we as doctors have control over when trying to make sure that people do well is actually picking good candidates for DBS. Many Parkinson's patients are or become or will be at some point good candidates for DBS, but many aren't. And so I want to talk a little bit about what makes someone a good candidate. And really the number one thing that we look at is confidence in the diagnosis, which may seem a little bit silly, but as many of you know, Parkinson's is not diagnosed by a blood test or by an MRI scan. It's diagnosed by smart, experienced doctors like Dr. Christine, like Dr. Amanoff, looking at you, examining you, looking at how you walk, how you move, and making a very, very educated, experienced guess that we think you have Parkinson's disease, and then putting you on medications and seeing if you respond. But even with world-class neurologists like the gentleman that are talking to you today down at this table to my left, every once in a while, one slips past the goalie, as we say. And so there are people that we've implanted with DBS that we really firmly believe they have Parkinson's disease, and they end up a couple of years later we figure out that they have something else. This is important because patients that have what we call idiopathic garden variety Parkinson's do really reliably get better with DBS. But if you have something else, if you have what we call a Parkinson's plus disorder or one of these atypical syndromes, you won't get that much better with DBS. And there are many things that impersonate Parkinson's disease. This is just a list of a few of them, but these are things like progressive supranuclear palsy or multi-systems atrophy. These are other movement disorders that, again, mimic or look like Parkinson's disease early on, but as time goes on, patients start to develop other symptoms that aren't consistent with Parkinson's, and they're consistent with these other things. Sometimes we can get a clue into this with MRI scan. This is why we like getting MRI scans of people, and you'll often get an MRI scan shortly after you're diagnosed with Parkinson's, and if you're being considered for DBS, you'll absolutely get an MRI scan if you haven't had one in the last few years. And sometimes we get clues in the MRI scan. If there's more atrophy or shrinkage of the brain than we would expect for your age, all of our brains are shrinking as time goes on, and I can guarantee you mine is way more shrunken than it should be for my age. But this happens, and there's sort of a normal amount of shrinkage that we see in someone who's in their 60s or in their 70s. But if we see more shrinkage than normal, that's what we call a red flag. That makes us take a step back and wonder, okay, is this really Parkinson's or is it something else? Sometimes Parkinson's symptoms are caused by bad vascular disease or blood vessel disease in the brain. You can see that in an MRI scan. And sometimes there are other neurologic disorders that have things that we can see. So brain imaging can help in some instances. But really, most of the time, it's the clinical course of the patient. If the symptoms come on very quickly, if you're normal in July and you have a little bit of tremor in August and you get diagnosed in September and you can't walk by December, that's a very rapid onset and progression of symptoms, and that's probably something else and not Parkinson's disease. Certain symptoms of your Parkinson's, if you get them early on, like memory troubles or instability with being able to stand upright, if you get those early in the course of your Parkinson's, it may be something atypical. And again, anything that's unusual that we see either by examining you as a patient or by looking at your MRI scan. One of the things that your neurologists use quite a bit to make sure that we think you have Parkinson's disease is to see if you respond to medications. And of course, Sinemet is really one of the cornerstone medications of Parkinson's disease. And one of the things that we do when we're considering someone for DBS is we really want to see how well do they respond to Sinemet. And we like for patients to have, even if they're advanced and it doesn't work like it used to, we like patients to have some response, and they should have some response to Sinemet. Now, oftentimes, you as a patient won't really feel that Sinemet is doing much for you. But when you're off the medication and a neurologist examines you in an objective way, they have you get up, walk a certain distance, sit down, they have you hold your hand out, look at your tremor, they measure your stiffness, they can score your severity of symptoms. And if you then take your Sinemet, you may not necessarily feel a lot better, but your score can change fairly dramatically. So we do this thing called on-off testing. We'll have you come in the morning, not having had any medication since midnight the night before. Your neurologist, one of our neurologists, will test you, then give you your Sinemet or whatever medicines you're taking, let it sort of kick in, and then retest you. And we like to see about a 30% improvement in your overall function. That tells us that there's something in your brain that's responding to this. And if you're responding to Sinemet, in general, you will respond to DBS as well. So we use this as sort of a marker to figure out who's going to get better and who's not. It's important to remember, and a lot of referring neurologists in the community don't have a good sense of this, but DBS, it really doesn't make you a whole lot better than you are when your medications are working their very best. We call that your best on state.
And so it doesn't matter if this is just for 3 minutes a day, in that sort of magic period, you've taken your meds, they may have made you dyskinetic, but that's calmed down and you're moving well, you're not having dyskinesias, but you haven't turned off yet. Even if that's for 3 minutes, we like to see that. We like to know, what do you like when you're in your best on state, because that's what DBS is going to make you like most of the day. And so if you don't have good function in your best on state, like for example, if you can't walk fairly independently in your best on state, that's a little bit of a concern. I mean, we're not really going to be able to make you better than that. And this is a misconception. People think that, you can be wheelchair bound 24/7, but we can do DBS and you can go running down the hallway. And that's not true. If your best on state doesn't get you up out of the chair, we can't do that either with DBS. Very important. What DBS does do is it makes the off periods more like the on periods. And so someone who's a good candidate actually is someone who has good function in their on state, but they're not there most of the time. They spend a lot of time either dyskinetic or in the off state. So, really, if you asked me, what's a great Cinemet profile for a patient? What do you like to see? It's someone that has a dramatic response to Cinemet or some response to Cinemet. There's a big difference between their on state and their off state, and they spend most of their time off. That's someone that will do really, really well with DBS. Make sense? All right. The degree of disability is important. And again, this is a concept that a lot of people that refer patients to us don't have a good handle on. So many people come to us a year after they were diagnosed and asking about DBS. And typically, medications usually do pretty well for the first couple of years. And if you're getting along, very even function, you're working, doing what you like to do, taking 3 Cinemet a day, why on the earth would you want us to put holes in your head and stick electrodes in there? Now, as a patient, you think, well, I don't like medications. I'd rather have this fancy electronic thing. And we are sort of rethinking, and there are people actually studying, is it okay or desirable to intervene with DBS earlier in the disease course? But for someone who comes in, they're not having dyskinesias, their medications are controlling their symptoms throughout the entire day, we generally will counsel them to wait. Now, why do we do that? Technology is changing all the time. These devices are getting smarter. The ways that we implant these devices are getting more sophisticated. The batteries that we put in that drive these systems are constantly getting upgraded. And so it's kind of like buying a computer. If you wait a little bit, you can often get sort of the next best thing, or we learn more about how best to treat people with DBS. So there's advantage if you're early on to waiting. There's also the other end of the spectrum, however, where people view DBS as sort of a last resort. You wait until your medications don't work at all, and you're stuck in a wheelchair 24/7, and then, okay, I'm going to go get DBS. That's also not a good idea. There is sort of an ideal window in which to intervene, and it's usually when you start to develop fluctuations in your function throughout the day, those on-off fluctuations that we talk about. So let's talk a little bit about memory and cognitive function. This is a really, really hot topic right now, and I mentioned earlier that memory troubles are a really under-discussed feature, I think, of Parkinson's disease. And memory troubles, whether they're mild or whether they become very severe and actually enter the category of actual dementia, this is a symptom of Parkinson's just as much as tremor is. Now, just as not everyone with Parkinson's will get tremor, not everyone with Parkinson's will get memory troubles, at least early on. But it's a very pervasive symptom, and it's very hard to pick up in casual conversation with people. We know that patients with impaired cognition don't do well with DBS for a few reasons. One, It's a complicated therapy. You have to be able to tolerate the operation if you're going to have it done the awake way. You have to be able to come into the doctor's office on a regular basis and be able to tell us or your neurologist, these are the symptoms that are bothering me. I'm still having freezing. My tremor's better. You have to reliably be able to tell us what's going on. And if you're having cognitive issues and can't do that, we have no idea how to sort of guide the programming of the device. We have no idea how to optimize the settings of the stimulation to make you as good from a movement standpoint as we can. The real big concern, however, is that we know that brains with memory troubles don't like to be poked with electrodes. And they particularly don't like to be poked on both sides of the brain at the same time. And early on, when we were doing DBS, we would implant just one side of the brain at the time. As we got better and the techniques got faster, we started putting both electrodes in on the same day. And we started to see a subset of our patients have significant memory problems, a lot more confusion right after surgery, and actually long-term memory difficulties after surgery. And so we've learned now to do very specific memory testing on everyone that we're considering now for surgery. And if we see anything that makes us concerned about any memory troubles that are present, we will just do one side of the brain at a time. Do one side, let the brain fully recover. Patients do get a symptom improvement on both sides of the body after just a one-sided implant, but most of the improvement is on the opposite side of the body. But we take it slower now in patients that have memory troubles, and it's really important. And I know it can be frustrating for patients, but it's safer for them in the long run. Age is another thing that really gets talked about, and many people think that we sort of have this magic cutoff. If you're above a certain age, we won't consider implanting you, which is categorically not true. However, age is a factor. If you are 75 or over, you will not get the really robust response that you might get if you were 55, let's say. And patients that are over the age of 80 get such a modest improvement that it's very rare for us to implant someone with Parkinson's over the age of 80. Now, having said that, I had a patient from Napa Valley, might be in the room, who was a very charming retired surgeon, was 82, and none of us really felt that he was going to get enough bang for his buck to implant. You know, there becomes this sort of risk to benefit ratio. Are the risks of doing this worth the benefit that the patient's going to get? But he's a very charming guy. He was a retired surgeon, so I felt sort of a kinship with him, and he basically talked me into implanting him. And the last I heard, he was 86 or something, and his goal. He loved to travel, and his goal was to be able to just get on an airplane without having to use a wheelchair. And that's basically what we did for him. And if you ask me, that's not much of an improvement in day-to-day function, but it made him very, very happy. And so, we do take it on an individual basis, but it's important to know that the older you get, the less bang you get for your buck, especially over 75. And then finally, other medical problems. So, there are other things that can increase your risk. Blood pressure is one of them. It's a very, very common problem. Many people with Parkinson's have low blood pressure. But if you have high blood pressure, it can be an issue. We need to be able to control the blood pressure in the operating room to make sure that the implantation is as safe as possible. And that can be challenging in some patients that have really bad high blood pressure. Also cardiac disease. So a lot of patients have heart troubles. They have these stents put in. People have to be on these blood thinners. They take an aspirin a day, or they take Plavix or some other blood thinner. Those medications have to be stopped for a week before surgery and have to remain stopped for a week after surgery in general. the risk of bleeding just becomes astronomically high if we try to do this operation with someone taking aspirin or Plavix, right up to the day of surgery. So most of the time, if you're on these kinds of medications, you can stop them. But every now and then we get someone with such bad heart disease, their cardiologist says, look, you can't stop taking your Plavix or you're going to have a heart attack. And in that case, we can't do DBS. So that's something to think about as well. And then there are other things like diabetes, which can increase the infection risk. If you have bad lung issues or rheumatoid arthritis and you have to take steroid medication, steroids can suppress the immune system, and that can also increase your risk of infection. So these things often don't stop us from doing DBS, but they can increase your risk. And so again, we'll discuss that with our patients on a case-by-case basis. And then finally, patient expectations. We're all Americans. We want to get better. We want to get better now. We want to be like we were when we were 16. And so it's important to remember DBS, it's a complicated therapy. It requires coming back to the doctor's office multiple times over the first 6 months or so after implantation to program the device. And it's important to remember, too, it doesn't cure Parkinson's. It doesn't cure Parkinson's, and it doesn't stop the progression. So towards that end, in the last couple of slides here, what are the long-term improvements numbers? What are the statistics with long-term improvements? And there are a lot of studies that have looked at patients, how they're doing 5 or 6 years after DBS. There are very few studies that look at how patients are doing beyond that. And in July of this year, a study came out of Italy. It was a fairly small number of patients. It was only 14 patients. But they were followed very closely for at least 9 years, some of them more. So I just wanted to share some of the numbers with you there. So if you look at the overall improvement, if a neurologist looking at a patient and scoring them, they had a 56% overall improvement at the first year. At their 5-year anniversary, they were still 45% improved. And at their 9 or greater year anniversary, they were 42% improved. Now that sounds pretty good, right? It varied though. So some of the symptoms, like tremor, stayed good for that entire time. So 70% improvement in tremor at the first year, actually 71% at 9 years. That's probably just a little statistical blip. But tremor seemed to stay very improved throughout this long follow-up. But look at these other numbers. So gait or walking, 68% improved in the first year, but only 36% improved at 9 years. And other things like your posture, being able to hold your balance upright or getting up out of a chair, almost 60% improved at the first year anniversary, but at 9 years, no improvements at all. And finally, this last slide. So these are function in the off state versus the on state. So a tall bar means you're not doing as well. So this is off medication before surgery, a very tall bar, so not doing well. This is with medications before surgery. So a big difference between off state and on state. This is before surgery. This is at 1 year after DBS. Look, the on and the off look almost identical, right? So this is what we were talking about earlier. DBS can make your off look like your on. Notice about the same as the on state before surgery. So that looks really good. But look what happens at 5 years and 9 years. Now this is activities of daily living. This is not the neurologist looking at you and giving you a score. This is you, the patient, telling us, well, I have troubles doing this, I have troubles doing that. So according to this graph, at 9 years, you look pretty close to the way you did, before you started. So I think the bottom line here in terms of long-term follow-up of DBS is that there is sustained improvement with DBS, but it varies from symptom to symptom. And again, DBS doesn't stop the progression of the disease. So during the years as they roll by, the Parkinson's is still getting worse despite the fact that you're being stimulated. So I'm going to stop there. I know we're having a little question and answer thing at the end, so hopefully my voice will keep going. And I appreciate your time. Thank you very much.